advisor for cardiovascular disease for Northern California Kaiser Permanente and a clinical professor at UCSF. Joining us today are our two primary investigators for the partner late-breaking clinical trials presented at ACC's showcase session, Dr. Craig Smith and Dr. Matthew Reynolds. Dr. Craig Smith is the chairman of the Department of Surgery and the chief of Division of Cardiothoracic Surgery at Columbia University Medical Center. Dr. Matt Reynolds is with the Division of Cardiology at Beth Israel Deaconess Medical Center at Harvard Clinical Research Institute. Also joining me on my left is to provide additional comments for the partner trials presented today are some of the leaders of our ACC 11 I2 Summit. Dr. David Molitano is the Chief of Cardiovascular Medicine at University of Kentucky and our I2 Summit Program Chair. Dr. Mike Crawford, Professor of Medicine, Chief of Clinical Cardiology at University of California San Francisco Medical Center, and our ACC 11 Program Chair. And Dr. Bharat Tushu, Professor of Medicine and Vice Chair of the Department of Cardiovascular Medicine at Cleveland Clinic, and our I2 Summit co-chair of this year's annual meeting. I'd now like to turn it over to Dr. Smith.
Thank you. I don't have any prepared remarks, as this is a good opportunity for other than the ones I just gave. I would be happy to review a little of that if you'd like, or you can open it up for questions. I know we're already running late, which is too bad. Would you like me to summarize?
Well, maybe if you gave us a few of your take-home messages for our nation's patients from your perspective of the study.
Okay. Well, the principal finding of this study was that comparing TAVR to the gold standard surgical procedure, AVR, TAVR in its current state of evolution is statistically not inferior to the gold standard in a high-risk population. Important to emphasize that at this point it's still a high-risk population. But the progress has been quite dramatic over several years. We already learned in the previous cohort presented in the fall that the TAVR is the standard of care really for inoperable patients, very high-risk patients who can't tolerate surgery. So this opens up a new set of patients who may very well be benefited as much by TAVR as by conventional gold standard surgery. As everyone knows, no one wants surgery, no one should want surgery, and equivalent therapy is always a good thing. I'll repeat it. You're probably right that that's the answer. What the question was, since the differences, the separation curves that's obvious at over the first 9 months tends to disappear in a year, and some curves they appear to be crossing. Well, you're correct. After a year was the end point. It would be statistically hazardous to speculate beyond a year, and also the numbers are getting smaller and smaller. Just a little hard to say. We notice this. What does it mean for the future? Only the future will tell us. The question was about complications of TAVR. The principal complications associated with TAVR in this trial were stroke and major vascular complications. Stroke, defined as all neurologic events, meaning stroke plus TIA, was significantly more frequent in TAVR than in the surgical control group. In a retrospective analysis that redefined neurologic events so that it could focus on major stroke, using a Rankin scale to define that, not surprisingly, because the numbers then would be smaller, it fell below the statistical threshold, even though there were still twice as many events in the TAVR group. So hard not to say that there's a signal, as the FDA likes to say, increasing risk of stroke in TAVR in its current manifestation. However, the risk of stroke has already come down pretty substantially from B to A, so we expect that will continue. Major vascular injuries are also significantly more frequent in TAVR, likely to improve with smaller devices and experience. Both stroke and major vascular injuries, if done by Kaplan-Meier curves or a couple of other ways to show the impact of those events on mortality, they do have an impact. Same, of course, to be fair, is true of the impact of major bleeding in surgical patients. Also has significant impact on mortality, and of course that's not surprising because people know that happens with surgery.
At this point, what I'm going to do is ask Matt to talk, have our panelists here give you a perspective, and then open it up further for questions. Matt?
Okay, sure. So if you were there at the session, we explained my analysis was a cost-effectiveness analysis based on a separate cohort from what Dr. Smith was presenting on. So this was a part of the partner trial program that enrolled patients who were found after review by cardiac surgeons and the central executive committee to be unsuitable, to be inoperable, essentially. So non-surgical candidates with this same condition. And those patients were randomized to TAVR or standard medical therapy, which sometimes included, actually often included, balloon aortic valvuloplasty. We looked at cost effectiveness over the projected lifetime of these patients. Those projections, the trial had a minimum follow-up duration of 12 months, but the lifetime projections are necessary in order to understand the return on the upfront investment, because most of the cost is incurred in the beginning. And our major findings were, first of all, the initial hospitalization. I'll mention as well, this is a U.S. trial. The vast majority of patients were enrolled and treated in the United States, and the analysis was done from the perspective of the U.S. healthcare system. We found that the initial hospitalizations cost around $78,500. A little over half of that was procedural costs. 12-month costs were actually higher in the control group from that point forward, because the control group was more frequently readmitted to the hospital for cardiovascular problems. At the end of the story, basically, based on lifetime projections, we estimated an $80,000 difference or incremental cost associated with TAVR, which is significant. But we also estimated a survival gain, which is also quite significant. So the average life expectancy in the TAVR group worked out to a little bit over 3 years, 3.1, I think, and the control group 1.2 years. So that difference is almost 2 years. So in this extremely high-risk population, an elderly population, the intervention is adding roughly 2 years of life, and that is the ROI, essentially. The cost-effectiveness ratio, when you do the math, it works out to just over $50,000 per life year gain.
Terrific, Matt. Questions? David, can you give us a perspective from that of an interventional cardiologist based on what we heard today?
Sure, I'll back up just one step, though I wasn't involved with the partner trial, so like many of you, I can be just half a step removed, and I will say that you are all witnessing history in the making. There's no question about it that those of you who were able to hear Dr. Smith's presentation, you really did see history unfolding. I would say it's probably will be seen as one of the biggest steps in cardiovascular medicine as far as intervention is concerned. Potentially in our lifetime, if we look back to balloon angioplasty, the advent of stents, and then drug-eluting stents, probably on the life scale of a calendar, this will be seen as the next major turning point or the next major step, and that will be the percutaneous valve intervention such as this. I'll make 2 other quick comments, and that's the impressive findings that I alluded to and Craig detailed, and that's the change already between partner B and partner A with the same device. A similar cohort of patients, a similar risk patients, we already see a substantial decrease in those things we're worried about. Mortality, for example, between partner B and A was decreased, depending on which you look at, the intention to treat or the actual receiving, but it decreased by 21%, and so too stroke between the two studies. 1 year stroke decreased by 35%. And so if we see that already early on with the same generation device, what more can we expect or hope for with the second generation device? And hopefully Murat Tuju can detail this a bit further. Partner 2, which will be comparing the next generation smaller device with the current generation device. So I think this is just fantastic and terrific. As Craig detailed, there's 3 major areas that will continually need to be worked on, that being perivalvular leak, which occurs in some patients, that being the major vascular events, which has already been being addressed, and that of embolization causing cerebrovascular accidents.
Terrific. Dr. Crawford, you have a perspective of that of a superb clinical cardiologist. How do you think this would affect practice?
Well, it's definitely, I agree with David said, it's going to definitely change the practice of this disease, because patients don't want surgery. As good as surgery is, they just don't want it. And if there's an alternative, then they're going to go for that, as long as the risks and costs are reasonable. Now, it was stated earlier in the presentation that for the B-type patient, the patients that are inoperable, this is the standard of care. That may be true in Europe, but it's not true in the United States, because it's not available yet. The devices are not FDA approved. We don't have them. And so I think, that's the future perhaps, but it's not here right now. The other thing about the cost analysis I think is interesting is that right now there's a big upfront cost in this, in that you have to have a special room to do this in, that you can both do surgery in and do interventional procedures. Usually those are done in different rooms. You have your surgical suites and you have your interventional cardiology suites, and they don't ever get together very often. But now you have to have what's called a hybrid room, where you have all the surgical things you need, plus all the imaging things you need. If you saw the excellent video that Dr. Tuju showed of one of these procedures, you saw all the imaging that's involved with this. And so there's a lot of cost right now up front to do this, not only in the facility, but the team, the people you need, all the imaging techniques that you need to have. So right now, this is only going to be done in major centers that can assemble teams like this once this gets approved. And it's hopeful that as we gain experience with this technique, that this upfront cost will actually go down, and the cost effectiveness will actually get better, because you may be able to trim off some of the imaging. Maybe this technique or that isn't really necessary once we get more experience. Maybe we don't need an operating room anymore once the percutaneous technique gets perfected. So I see the costs coming down over time.
Terrific. Murat, I was wondering if you could give a surgical perspective related to this, and maybe even comment a little bit about the case from your perspective, and even the utilization of such in this format.
I don't know if I can give a surgical perspective, as I'm an interventional cardiologist, but let me just say that I know more about surgery now than I started this journey about 5 years ago, because I work with my surgical colleagues much closer than I work with many of the cardiologists in my department. And that I want to focus on, which we should not lose sight of. These extraordinary results, we feel that these results are extraordinary, are accomplished because of a true teamwork, an unprecedented teamwork between a cardiologist, cardiac surgeon, and the imagers, clinical cardiologist, and the associated caregivers. But I just want to emphasize that if we fail to not pay equal attention to what we have done in this trial after the device is approved, I don't think we will be able to replicate the same results. The cardiac surgery profession and the cardiology profession had a very sometimes not easy relationship over the last, particularly interventional cardiologists and cardiac surgeons, over the last 50 years. But now, over the last 5 years, as evidenced by this trial and how we interacted with each other, how we formed a single team, really is diagonally opposite, and it shows that both sides took enough lessons. So I think that it is critical to emphasize that. I think from the surgical perspective, it is important to appreciate that the world is changing both for cardiologists as well as cardiac surgeons. Not all cardiologists, not all interventional cardiologists will do these procedures. Not all surgeons will be involved in doing these procedures, say transcatheterically, because this really requires not only a different skill set, but also a dedication, a time commitment to this particular area. So I think what I wanted to show in that live case is really highlight the fact that it is not just the person who's putting the catheter in that's doing this procedure. It takes a village really to perform these.
Excellent point. I'd now like to give the press a chance to fire some questions at the panelists or, of course, at our august presenters. And there's a microphone up front. Please identify yourself before you offer your question.
Thanks very much. I'm Marilyn Mercion from AP. Question for Dr. Smith. Your slides, a couple of your slides seem to show data out to 24 months. I know you didn't present any endpoints, but it looked like you had some longer than 12-month data, and it looked like, especially on the survival overall and the major primary endpoint, you had 2 years older. If you could comment on that.
That's similar to the question was raised earlier. It's difficult to make any meaningful comments on that because it's past the primary endpoint. Because it was a sweep analysis, we do have good data out well past a year in most patients. That going forward, perhaps we'll learn something from it. Even so, in terms of the real questions about durability and long-term, adding a year to the follow-up may not be enough to make meaningful conclusions.
One more quick question. If you could please help us understand the decision to add the major stroke as a secondary endpoint. It was not your primary safety endpoint, and it looks a little like shopping for an answer. I just wondered if you could explain a little bit about why you did that, because you pre-selected a different safety endpoint.
Well, you just posed the strict trialist's view of what went on, for sure. Was it really a retrofit looking for the right answer? I don't think so. The question of when B was submitted to the New England Journal, they immediately asked, well, what about major stroke? So, at least in part, the retrospective analysis was an attempt to answer that question. And it came up not just from the reviewers, it came up from other people saying, well, is TIA really a meaningful event? So you're correct that to go to a non-pre-specified endpoint in a randomized trial is perhaps not completely kosher. And it's not at all surprising that if you do an analysis retrospectively, it reduces the numbers of events when the events were not occurring at such high frequency that they would necessarily have power anyway. But it will start to fall below the level of significance. But people were interested in major stroke, not just the people trying to retrofit the answers.
Hi, I'm Shelley Wood from theheart.org. You said that the secondary endpoint of non-inferiority in the transfemoral group was actually powered for that analysis, and it showed that it was also non-inferior in the transfemoral group only. Did you also do a superiority analysis with the all-cause mortality in the transfemoral group?
We did not. As you can see, just from the 30-day procedural, well, in the early period, the trend is very much towards superiority, but didn't achieve it. But it was not designed to test superiority, so we didn't do it.
30 days either?
None of these endpoints were powered at 30 days. It was all in 1 year.
Thank you.
Bernhard Horn from Germany, Journal of the German Medical Association. Dr. Smith, could you please give me a number about the percentage of the patients needed a pacemaker after the procedure?
3.8% in that range, 3.8, 3.9, somewhere in both groups. So relatively low and well within what we would expect for surgery at least.
Okay. And the regurgitation was a problem, a clinical problem with symptoms or asymptomatic?
Regurgitation? There were no symptoms that we've been able to identify. There have been, and this applies to B as well. Following these people now, sometimes 2 or 3 years, we haven't been able to identify symptoms in the vast majority, or that this is having a major consequence. There have been 2 patients who required late balloon valvuloplasty or other touch-up of late regurgitation, and a small number of patients have required surgery late, but it's been a relatively infrequent event. And up to this point, the consequences of this mild, moderate regurgitation don't appear to be very extreme.
Thank you.
Michelle Cortez with Bloomberg News. A number of you have mentioned that patients are going to prefer to have something non-surgical rather than surgical if they have the option. I imagine that they really won't care very much about what their risk score is, whether they're high risk or low risk. I'm wondering if each one of you can address that issue, what you're going to say to patients, what the appropriate use is for this, how you're going to manage those expectations. And if you could wait to answer until I sit back down so I can type, I'd appreciate it.
Do you want me to start?
Yes.
Wait till I hear the clicking of the keys. Well, as I guess one surgeon on the panel, in a sense, my story won't change because the risks of surgery are very familiar to everyone, and they have a lot to do with the fact that no one wants surgery. So my story doesn't change too much. Although I must say already, practically every day in my office, I have to explain this new procedure, where it stands in development, what we know about the risks. I can now say quite a bit more now that we've released these results. I think the onus now shifts to the interventional cardiologist and general cardiologist and internist, because they have to explain not only the traditional sort of a view that surgery is a bad thing to have. They have to explain this new device as fairly and honestly as they can, including all the pros and cons. Well, that's not a new thing. Obviously, that's incumbent on any proceduralist. But this is a procedure that doesn't have trivial risk, and it will be important as it moves down the risk categories to be honest about what the risks are. Even though, as I happen to believe, and I think most people do, it will march steadily down the risk categories with fewer and fewer complications. In the interim, we have to be honest about it.
Sure. Well, I'm a clinical electrophysiologist, so I don't do either of these procedures. I don't have a dog in the fight, so to speak. I'll just put in their pacemakers and defibrillators either way. I think I agree completely with Dr. Smith's point, and it's important. I think that the risks of surgical valve replacement are pretty well understood across the risk spectrum. It's a mature procedure, and the outcomes are excellent. The outcomes of TAVR in a lower risk population you might expect to be somewhat better than what we're seeing in this high risk population, but they are not known. So people talking to patients have to be honest about that. It could be that there is some point where surgery might be preferred, but those decisions are going to have to be made with incomplete information.
Yeah, I'll add in a couple of comments. One, Mike Crawford already said at this point, since the device isn't approved, we won't have to quite face that yet. On the other hand, we certainly have faced it already because of the randomized trial that's out there. So we've had patients in our practice who we knew were inoperable, and we said, here's an opportunity if you're willing to go to one of these 20-some centers in the United States and have it done. And there have been patients who have needed to understand the risks, the benefits, and the alternatives, and we have sent them to those centers. I think it was easy. We knew that for every 5 of those patients that we were to send along, as compared with those who did not get any operation, that one of them would have gained their life, basically, because of the mortality being absolutely 20% lowered in the Partner B study. Now, I think at Partner A, it's going to be tougher. I think to Craig's point is we really need to make sure, one, they're inoperable. That it's not just a surgeon who doesn't want to operate, but they're truly an inoperable patient. And then second is, are they truly a high-risk patient? So I think it will take practicing cardiologists some extra effort to be sure they learn and understand the risk scores, the STS, the Euro score, whatever they may be, and make sure that they understand them well and can explain them to their patients. They're now on like the iPhone and things like that, by the way.
Do you want to comment on the issue of low-risk patients?
Yes, well, this is, we're going to be driven by the consumer. The consumer's going to want non-surgical approaches, even if they're low risk for surgery, and would probably do really well with surgery. And they're going to want to know all the facts. And the problem we're going to have is trying to explain this to the patient and inform them. It's always difficult when you have all this kind of data, the pros and cons of each approach. But it's also going to be difficult to study this, because the lower the mortalities get from anything, the harder it is to show a difference between two things. So I think that's going to be a challenge for the upcoming studies in the lower risk patient. But right now, I've been facing this every day in practice, because I live in San Francisco, where people often think nothing of getting on a plane and going to Europe, where they could get this done, presumably, if they had the wherewithal. So it is an issue in some areas of the country right now.
In 1980s, or since 1980s, interventional cardiologists were usually criticized because we made the diagnosis, we saw the patient, made the diagnosis, determined that they needed a PCI, performed the PCI, evaluated the results. So this can't happen in transcatheter aortic valve therapeutics. That's why we have to continue our work together with the cardiac surgeons, if not with other team members. But I think that here the decision will be made by cardiac surgeon and cardiologists collaboratively, and that will assure that patients are well informed, know that they have two options to choose from.
Question?
Roger Sir, with ABC News. Two-part question. First for Dr. Smith, then for everybody else. Dr. Smith, when approved by the FDA, will this have an impact of thousands of patients, tens of thousands of patients, hundreds of thousands of patients?
Well, initially, it'll be thousands as the inoperable cohort is approved, but I think we'll pretty quickly become tens of thousands. Probably a number of years before it's hundreds of thousands.
And a show of hands of everybody else, a practice changing by tens of thousands? Yes? No? Can you raise your hand if you believe that will change practice by tens of thousands of patients? Excuse me?
It has to be approved, and in what time frame would be another part.
Once it is.
I completely agree with Chris. That's good.
I think with Dr. Crawford, we can change practice by tens of thousands of patients.
Oh, definitely. I think once it's out and approved and gets disseminated across the country, which is going to take a little while, you're talking about hundreds of thousands.
Yeah, I would agree. It's just a matter of a time course, but like I said early on, this is a historic event. This will change practice. Things will only get better, and it will lead to hundreds of thousands of patients eventually, yes.
Yeah, and so addressing your point, the best guess is there probably 30% of our nation's patients with severe aortic stenosis are not being referred for surgery now, who are decent and candidates for aortic valve replacement. Now that could be due to a couple of reasons. One, it may be due to misdiagnosis, or it could be that either the patient's primary care doctor, internal medicine doctor, or even their primary cardiologist has made an assessment on their own that this patient may not be suitable, or the patient or the family have decided such. So I think this is truly going to be a game changer. There's a huge amount of patients out there are not getting therapy, and when they're approached with a team approach and there's involved shared decision making with the patient, that this will have substantial changes. Now, I asked about the time frame because it's going to take a while to ramp up the expertise in the centers, which actually I'm going to take the liberty to make one further statement, which is we as a profession have to be responsible in terms of the diffusion of innovation, of new technology, this landmark technology that David has talked about into the community. Not everyone should be doing this. In fact, I found fascinating, and it was referred to, that because they were high-volume centers, even the aortic valve replacement mortality was low. It tells you the advantage of a big team approach and excellence. So how can we as society, responsibly with the FDA, with payers, with professional societies, put together proper programs for innovation of diffusion of these new technologies? We need to develop competency statements. We need to develop definitions of what the multidisciplinary team is. There are a lot of things that need to be put in place that will be to ensure that as this genie gets out of the bottle, that we can reproduce the results and make sure that we monitor safety and efficacy as it gets delivered into the community. Next question.
Trying to catch up with you, Bruce. Ron Winslow from the Wall Street Journal. I just want to expand a little bit on this. What is the size of the population currently that has aortic stenosis that's getting treated surgically? I'm just trying to get a little bit more perspective. I mean, you do 1 million angioplasties a year. How could you put this as a sort of an annual market, if you will, currently, and then as this rolls out to a lower risk population?
Well, in real big round numbers, it's 150,000 or less annually, and about half of those are concomitant AVR with coronary bypass.
I think most experts are quite optimistic about the future of the device. So my question is, how many of you would be considering of designing trials to prove its efficacy in younger and maybe less severe ES patients in hope to expanding the indication of this TAVI device?
Well, that goes straight to the design of the Partner 2 trial, which is already likely to be aimed at much lower risk patients. Exactly how much lower risk is still a discussion that's ongoing, but the results presented today would make it hard to do another trial at this risk level when the TAVR, the TAVR mortality was in the 3.7% range.
Hi, this is John Camp from Dow Jones Newswires. Dr. Smith, I wanted to follow up on the stroke question because it did appear that they weren't really all procedure-related events with the transcatheter valve, and so I wanted to get a sense of, over the course of the year, do you have an idea of what the mechanism of action was for those strokes? What was it related to the procedure that might have been causing them even months down the line?
Well, here I will disappoint you because a much fuller story on stroke will be presented as a late-breaking trial at the American Association of Thoracic Surgeons meeting a month from now in Philadelphia, so some of this is information we deliberately haven't turned over yet. Taking the lesson from cohort B, we know that many of these strokes don't occur in the first 2 or 3 days. They do tend to occur, the major cluster is technically in the first 30 days, but there is an ongoing low incidence of stroke as time goes on due to the usual things, atrial fibrillation, hemorrhagic stroke, what have you. It becomes a rather complicated analysis with relatively small numbers. But a more complete discussion of this, go to the AATS meeting.
Rock?
I want to make 2 comments on stroke. Comment number 1, we have a very valuable data set because all of our patients were examined by an independent certified physician for neurological status before and after, before discharge. So that is a prospective evaluation of neurological status that you will find hard in all others registries that were reported and giving various stroke rates. So that's critically important. And it's well documented, so we feel strongly that major stroke classification is quite accurate. The second question is we do not know, and Craig is right, that we are all looking forward for the sort of in-depth analysis of neuro in AATS meeting, but we have some signals in cohort B patients. Of the 23 neuro events throughout the follow-up period, 5 strokes and some TIAs occurred, but 5 strokes occurred within 3 days of the procedure. So until then, we used to think that the stroke rate was high because we were doing something to the valve and then there was embolism. But it's clear that, like many things in medicine, it is much tougher to crack than we initially thought. So we have a important task in front of us that we started to shave the numbers of strokes, rates of strokes, but I think to shave it further, we can't only look at the procedure-related problems, but further to our antithrombotic, anticoagulant regimens and strategies throughout the follow-up period.
Very important point.
Just one quick follow-up on that. I heard mention that perhaps the stroke rate and the kind of vascular complications rate went down a bit for cohort A because there was some experience gained with using the system, et cetera. And I wanted to just kind of make sure I understood, chronologically speaking, were doctors who were treating patients in cohort B typically doing those patients first, and did they have a little bit more experience with the system by the time they were working in cohort A?
B was a smaller number. That was completed first, and enrollment and accumulation of experience continued in A beyond the point that B closed. So in that sense, there was an opportunity for experience, greater learning curve and so forth to show up in A potentially. It's a long way from saying that's proven, but it's potentially true.
Hi, Melissa Walton Shirley with theheart.org. I noticed in the initial partner inclusion criteria that patients with predominantly aortic insufficiency were excluded. So we have a lot of patients with mixed valvular disease, AI and AS. So my question is, at what point can patients with aortic insufficiency look forward to having a TAVI procedure? And from a technical standpoint, other than the annulus size, is there much difference? And are you concerned about suddenly changing the dynamics of the ventricle with AI? Or, you know, I have a lot of patients with mixed disease, so when will they get to participate in these trials?
Right now, the engineering for a balloon expandable valve and for the nitinol self-expanding valve faces a real obstacle in pure AI with no calcification. If it's mixed AI based on what's essentially severe AS with a valve that's just stuck open, you know, then that's probably very good for TAVR. But the engineering right now really depends on something to fix against, and the early experiences in sort of in vitro and so forth with the AI model with a flexible, dilated, non-calcified annulus are not very encouraging. So it may take improvements in technology of a whole different order to attack that population.
And I noticed today that, oh, I'm sorry.
We included all mixed AS-AR patients as long as they don't have 4+ aortic regurgitation.
I noticed today's presentation that lady had some pretty significant AI, I thought.
That's right, but it wasn't 4+ aortic regurgitation.
Okay.
It was 3+ aortic regurgitation. So as long as it is mixed disease that predominated by calcific aortic stenosis, we do not have a problem.
Okay, thank you.
Hello, Justine Cadet with Cardiovascular Business. To Dr. Windus's point about controlling outcomes if this gets approved, do you see payers such as CMS putting a volume threshold on reimbursement, and is that something you would recommend?
I think this, I'll give you my own point of view. I think this is a night of a ripe discussion. I will say that I'm particularly proud of the STS and the Mike Max leadership and our colleagues in SCAI and the ACC as we work with the FDA in trying to come up with proper recommendations of this diffusion of this new technology. This is not an easy answer. The one thing I will say is that it's important that we actually evaluate what we're actually doing, and that is, again, it's sort of my background, but I think that we should almost mandate a registry of what we're actually doing in the clinical community so that we can monitor the safety and efficacy of new technologies such as this, which are landmark, and making sure that the things that we expect or deserve for our patients based on these randomized clinical trials can be reproduced in the community. And I look to guidance from all the stakeholders, whether it be industry, FDA, payers, and the professional societies, to work together to try to make sure we do this responsibly. Do you have any other comments? I know we have a question on the phone. Maybe this is a good time for that.
Yes, we do. We have a question from the line of Mr. Thomas Ma from the Los Angeles Times. Please proceed.
Questions. One, can you tell me a little bit about the vascular complications, what that entails? And secondly, the commenters. Could you folks please spell your names so we can get them correctly?
Murat, you want to do the vascular?
Vascular. Yeah, my name is Murat Tuzcu. And the vascular complication included essentially any femoral artery trauma that required intervention, be stenting or surgical repair or patching, and a substantial amount of bleeding. These were included in the vascular complications.
Could you spell your name, please?
Last name is Tuzcu. First name is Murat, Murat.
If you stay online, we can have staff help with the spelling of the other presenters and panelists for you.
Okay, great.
All right. Any other questions in the audience or on the telephone? Thank you very much. Oh, one more. I'm sorry.
I was just wondering if you could, I was unable to attend the conference this morning, and I was wondering if you could describe the difference in the new device versus the type of device, the type of valve that goes in the open heart surgery, and also the difference between the current generation and the next generation.
Well, to put it really simply, the surgical valve that would be most analogous to this valve has a little bit more structure supporting it. It has 3 stents, and so it's a little bit bulkier, and it has a sewing ring so that it can be sewn in place. This valve doesn't have any of that because it's held in place by the compressive forces applied by the balloon. So it has, in fact, in vitro testing, a little bit larger orifice area, which may translate into some benefits. So they're a little bit different structurally. They are both, however, bovine pericardial flaps that make the valve. Maybe Murat can talk about the next generation interventional device, which is smaller.
Yes, the new device is not cobalt chromium type of metal rather than stainless steel, and then there was a little improved treatment for protection of the leaflets, but it's still bovine leaflets. So and the most important, one of the important innovations were being able to put this balloon and device separately, just back to back, and reintegrate them in the body after getting into the aorta. That allows us to use a 19 French sheet instead of a 24 French sheet, or for a smaller valve, an 18 French sheet instead of a 22 French sheet. So that we think that the valve is better, and the delivery system is certainly smaller, and we hope that these 2 innovations will make our numbers even better.
Other than French? So roughly a 24 French is around a third of an inch.
Right, slightly more than a third of an inch is now coming down to slightly more than half of an inch in diameter. Quarter of an inch. Yes, third to a quarter.
All right, thank you very, very much.